Hello, this is Manny Ramos, your host of Rise Up, Real Issues and Stories of Every One of Us podcast. But first, let me talk about who we are. I'm Manny Ramos, a board member of PNAA and a past president of the Philippine Nurses Association of Central Florida. I'm a professor of nursing at Valencia College in Orlando and an adjunct faculty at William Patterson University. With me today is my co-host, Mindy Ofiana. Mindy?
Thank you, Manny. Hello, everyone. I'm Mindy Ofiana, Legislative Committee Chair, Corresponding Secretary for PNAA Foundation, and past President of PNA Southern California, and an adjunct faculty of Charles R. Drew University of Department of Medicine and Sciences. Manny?
Thank you, Mindy. Our guest tonight is Wilhelmina Ungco. Willy, as she is fondly called by her relatives and friends, has been a registered nurse for over 40 years. She received her Bachelor of Science in Nursing from the University of the Philippines and was a past president of the University of the Philippines Nursing Alumni Association International. Willy was especially trained as a continuous renal replacement therapy RN and worked as a team leader and charge nurse in the intensive care units. She implemented the early progressive mobility program in the ICU, which resulted in the decrease of hospital-acquired pressure ulcers, decreased ventilation days, an ICU length of stay, and improved with an early discharge of patients. Willy, welcome to Rise Up.
Thank you so much, Manny. Thank you, Mindy. It's my pleasure to be a guest tonight.
Good. Well, hi, Willy. Good evening. May you share with us, where did you grow up in the Philippines?
I'm from San Fernando, Pampanga, but I'm half Kapampangan and half.
Oh,
Mindy and I can relate
I
to
know,
that.
the second place you've been.
I'm Ilocano too, and Mindy too. Yeah, so good to know. Yeah, so Willy, can you please tell us why you decided to become a nurse?
Well, when I was in fifth grade, my grandfather had a fatal stroke.
Oh.
But I don't know. In my young mind, I had a feeling that something could have been done to save my grandfather.
Mhm.
So that's when I felt this strong calling to be a nurse, if not a doctor. So that started it all.
Mhm.
And what do you know? I mean, these days we know that time is brain, so to speak, right? So if we know the signs, the early signs and symptoms of a stroke, there's a big chance that the stroke would be reverted.
Mhm.
So that's how it started for
I
me.
see. So, when did you immigrate here in the United States, and what made you decide to come over?
I came over in August of 1982. I initially worked as a staff nurse in the Philippine General Hospital in the medical wards, and later on in the neurology ICU. I was frustrated because we didn't have the necessary equipment
Mm.
in the ICU, just like what I read in the many US published nursing journals, such as the nursing series, if you remember
Mhm.
those, Nursing 75, Nursing 76, and so on and so forth. And of course, we have the AJN.
Mhm.
So
Yes.
I read a lot about the swan guns, most especially, and I was just fascinated because in the ICU back home, we did a lot of, how do you call this, we just improvised.
Ah.
So we did a lot of improvisations in ICU care. There was no swan guns to measure the pressures in the different chambers of the heart.
Right.
And that was crucial for treating left-sided heart failure, right-sided heart failure, pulmonary hypertension, and all sorts of cardiovascular emergencies. And the way we measured the central venous pressure was even antiquated, that pipette glass with calibrations, and then you ran saline or dextrose into fill up the top of the pipette, and then slowly open the stopcock to the patient's circulation. And that was really crude, but well, it saved lives. It saved lives. But the technological advances that we have in critical care these days is just mind-boggling. Right. You can predict what's gonna happen, and you can apply the necessary interventions to prevent death even. So that's what really strengthened my endeavor to immigrate. And of course, it's the financial aspect, that's very important, because coming over here gave you the financial independence. Right. And as we know, according to Maslow's hierarchy of needs, I mean, we don't stop at meeting our basic needs. You go from the basic needs to the human instinct to help others, not only your immediate family, but in general, right? So, yes, I mean, I knew that I wouldn't be fulfilled if I did not grow career-wise, and if I didn't prosper financially. And there was no way you can really achieve the kind of financial success that you can achieve here back home. So, I mean, even up to now, the nurse's salary is like, I don't know. I mean, I think they don't even meet the minimum requirements, for daily living
over in the Philippines.
With the salary that they have, and that is really sad. And I just wish that at this point something could have been done to alleviate the plight of the Filipino nurses back home with regards to working conditions and salaries.
Right. So working in the 80s, starting to work as a nurse in the 80s in the Philippines, where you had to use a lot of your ingenuity and resourcefulness. Then you immigrate to New Jersey, right, Willy? Was it New Jersey?
First, I was employed in New York in Cabrini Medical Center for...
Wow, the big city right away. So how was that life in New York City as a newly emigrated nurse? How was that for you?
For me, it was everything I expected, because I think we were in the right place at the right time. I mean, myself and my classmates, we were 13 at that time. We were the first H-1 visa recruits,
right,
in Cabrini Medical Center. And everybody were very supportive at that time. we really got the critical care course training that was necessary for us to adapt to the new surroundings.
Right.
And also, there were Filipino nurses already there in Cabrini Medical Center. I think they got to be there because of the J1 visa, the exchange programs.
Right.
So yes, so this group of hospitable Filipino nurses took us under their wings and not only helped us in our daily life in the unit, but they also taught us how to be street smart and to navigate, and to navigate the New York City life. So it was really fun because during our first few months, we were always invited to dinner in somebody's house. So I had a lot of fun during that time, and being in a big group, 13 of us, made it easy because if you remember, we used to read the news about nurses committing suicide because they were lonely, they were alone, and they couldn't cope with the.
You're talking about immigrant workers like nurses.
With the culture. So, but for my group, it was different because after the critical care course, after the stint in the unit, we had places to go. We had parties to go to. We went to sightseeing. So it was great.
Good.
As you were talking about ICU care, and I'm an ICU nurse. So I'm just remembering all the experiences too that I have. So the pandemic affected all of us in one way or another. What did you experience during these unprecedented times? And what changes did you experience in your work or private life?
We had the first cases of COVID-19 as early as the last week of February 2020.
Yes.
And at that time, there were no guidelines and, policies and procedures in place on how to deal with this pandemic. So it was scary and it was disappointing and discouraging because the people in the leadership, meaning the management and the administrative echelon, didn't know. And I'm not exaggerating. They didn't know what was happening, and the fear and the lack of knowledge really, showed in how they conducted themselves. So all the more I got scared, all the more other nurses got scared because the ones that we trust to know more than us didn't know, and I cannot even say didn't seem to know. They really don't know what was happening because every day we were making up guidelines as as the days went by.
Right.
And it was also sad because I remember an incident early on within the first week when from the last week of February to the first week of March.
Yeah.
So this is what happened. Let me just say tell the story as it happened. There was a patient who came in with a fever, but he had a runny nose. So we were told it's not COVID because from what the data that they were gathering at that time,
Right.
through COVID-19 infection doesn't produce mucus secretions when you cough, and you cannot have a runny nose. You don't have colds. That's what we were told. And at that time, there's no certainty. There was no diagnostic tool for COVID-19 because the Department of Health and the CDC were not in sync. And I don't know who refused to issue the PCR kits. So we didn't have any COVID-19 test kits in the hospital. We were not allowed to test suspected cases at least in the first 2 weeks. And I'm talking the last week of February and the first week of March.
Right.
So knowing that it was viral, my coworkers, my team, we decided to do our own infectious disease protocol, which is what do you do if it is viral, like flu? You wear the N95. So we did that, and then we adapted the full PPEs. Those blue gowns and gloves.
Yeah.
And we, on our own, without waiting for directive from the infectious disease department, meaning the infectious disease nurse, we isolated the suspected patients with suspected COVID-19 patients.
Right.
So we put them in the negative pressure room.
Right.
And you know what happened? The infectious disease control nurse reprimanded us.
Oh.
Okay, so that was, strike one for me. And then at one point in time when the whole ICU, 30 beds, was filled with the COVID-19 patients from bed 1 to bed 30.
Wow.
The chief, the MD, chief of infectious disease control, came into the unit because at that time we were discussing, shall we give remdesivir, convalescent plasma. She saw the signs on the walls, no eating in the nurse's station, no drinks, no food in the nurse's station.
Right.
And she remarked, this is unnecessary. We're in the midst of a pandemic. You can drink, you can eat in the nurse's station. So what happened to our nurse leaders at that point? It took a doctor to be a pro nurse and say, to age with all these rules. It's the pandemic. We don't really know what's happening. We don't really know for sure how it's being transmitted. You need to drink. You need to eat, which is true, So, okay, so that's
so it's
another.
It sounds like
disappointment. Where's the nurse leader?
Yeah. So it sounds like in those early times, when COVID was new to us and there was not a lot of knowledge yet being generated, there was not, the protocols that we have now were non-existent. The vaccine wasn't available then at that point, right? And the treatments were still being researched. All of this must have How did that affect you and your peers? Because I can sense it was really very hard to work in that type of environment.
Yeah. So, and one other thing. So, my one coworker started putting on the cap.
Mm.
You know, a few weeks after the pandemic, people made a lot of money making those caps,
Mm.
like in different designs.
Mhm.
So the very first time that the infectious disease nurse, so one person wearing that cap in the unit,
Mm.
she reprimanded that nurse and threatened her with a write-up.
Oh.
So what do you know happened there? We wrote HR. We wrote to the risk management. You know, we made a letter saying that, you know, we don't know how this thing is being spread. So why are we being stopped with the frontliners? Why are we being restricted in observing all the necessary measures to prevent being, contaminated or, being infected with this COVID-19? And yeah, it was very scary because there was no vaccine, and every day you get differing news about how it's being spread. There was even a study that showed that after 1 week that a room is vacated, there were still aerosolized particles of COVID-19 like hovering in that room 1 week after the room has been vacated. So it was really very frustrating. And one other frustrating factor was the N95. I'm talking about the real N95, the blue, the 3M. There was a scarcity of the true N95. So do you know what they made us do? We had to use one N95 for 1 week. So you put that on, and then over it you put the regular mask. So the regular mask, you keep changing that as you enter and exit the patient's room. But that N95 stays on you for 12 hours. Because you're scared to remove it because, you don't know what's going to happen if there's a leak. You might inhale whatever COVID-19 virus is hovering in the environment. So at the end of the shift, you remove that N95, you put it in a paper bag with your name on it.
Yep.
It got autoclave. I don't know how they sterilize it. And then the next morning, it comes back in a plastic bag with your name on it, and then with a mark, 1. That means you used it once. So you use it for 5 times. And after the 5th time, they give you another N95. So that's another thing I didn't want, I mean, I told myself I cannot. I think this COVID-19 pandemic will linger. And I'm not gonna be wearing that same N95 for a week for another year, another 2 years. So that was playing at the back of my mind. That's why when the ICU was emptied in July, which is expected in the summer months, the ICU gets emptied. And you only have like 1 or 2 patients. After we discharge all the COVID-19 patients, that's when I said, I'm going to leave. I mean, I didn't leave during the crisis. After all the patients were discharged, I said, it's time to go. So that's what happened.
So as I was hearing you speak with regards to your dissatisfaction during the early part of the or early part of COVID, of the uncertainties and many challenges with regards to your material management or protective equipment, it also reminded me of when HIV started and Ebola. Right, there was so much things of uncertainties. Changes every day, standards are changed every day. When you come in the morning, it's going to be brown, and then when you come in and the next day it's going to be yellow. So how did that affect you, other than the dissatisfaction with leadership? How did that affect you as an ICU nurse and your co-workers as you were taking care of these COVID-19 patients? Because you still have to take care of them, right?
Yes, we still took care of them. In fact, we instituted a lot of algorithms to with a, how do you call this, positive patient outcomes, isn't it? I mean, that's what they love to talk about, positive patient outcomes. And on the good side, on the happy side of my experience with COVID, we didn't have any true COVID-19 deaths. That's one thing I'm very proud of, because of the guidelines and the PNPs that we instituted. So this is what happened with the COVID-19 pandemic in my ICU.
That's nice to hear.
After the second week of March, every bed was filled with intubated COVID-19 patients. And we had to take care of 4 patients each. So that was the challenge. And it's a good thing, though, that, the medical ICU team, the doctors and the chief of the ICU, they were really proactive, and they were pro nurses too. So they work with us really. So this is what we did. All the ventilators and the machines were outside the patient's room. Because they found out that to decrease the probability of getting infected with COVID-19, you cannot stay in the patient's room for more than 30 minutes. 30 minutes is the maximum time that you can be in the patient's room. And so because the COVID-19 doesn't produce secretions, there was really no need to go into the room and then suction the patient. And there was no need also to turn them every 2 hours, because they were so unstable. And the proning protocol is one of the PNPs that we instituted on the spot. We had a proning team with at least 6 people. One person at the top of the head to protect the airway, the ET tube, and then one at the foot, and at least 2 on each side of the patient, depending on the weight of the patient.
Right.
And this is really not very hard, because we had to keep them prone for 18 hours. That was the evidence-based that you had to keep them prone to promote oxygenation, in the lungs.
Right.
And the blood flow too. So that's what we did at that time. So we had the schedule, for 18 hours, the patient was on the back. And then the rest of the patient was on his back or her back. And as I said, the IV machines were outside the room. So, you know what we did? We had extensions, these pediatric IV tubings that we slipped under the door so that we don't have to keep opening the door to check, like, when the pump is alarming. Same thing with the ventilators. The console of the ventilator was outside, so we can monitor what's happening to the patient. And the family care was a very important aspect of the patient care during that time. I heard that so many people couldn't visit their family, which is understandable because we really didn't know how this bug got transmitted. So to make it a bit, easy on our family members, we bought several iPads. And we trained our nurses' aides to operate the iPad, the FaceTime. So when a family calls, we connect them to the iPad, and even if the patient is heavily sedated and paralyzed, the family could see the patient's face in the screen of the iPad. So that's one thing. That's a big achievement for us, really, to take care and to support, to provide the emotional support to the patient's family. So there was really nothing much to do in terms of bedside care, because as I said, you don't really suction them. You cannot suction them because it will aerosolize, whatever you suction, even if the suction system was closed system. But they got the care that they needed, which is really the medications. And we were using off-label medications then, the remdesivir, and then the hydroxy, what's this? I forgot the name. The malaria medication. Now I forgot because I'm not in the unit anymore. So there were two other anti-rheumatic arthritis medications that we also used off-label. And I don't know. I mean, I don't have the data, but as I told you, none of our patients died of COVID, like pure COVID. The ones that died, they were very, very old and had a lot of comorbidities. We had 2 or 3 patients who were in the ICU from the first week of March up to May. But they went to the rehab because they had tracheostomies. So they couldn't go to a subacute.
They have to go to subacute.
Oh, I think they were in the subacute rather than the nursing home. They couldn't go to the nursing home. They couldn't go to the rehab because of the tracheostomy. So they had to go to the subacute placement like Kessler. And so some of them came back. Some of them came back. The ones that we thought were dying or died in the subacute facility, they came back walking to thank us.
Wow.
And I'm having goosebumps telling you that story, but it's really like, it's incredible. It's amazing.
Ay, wow. That's nice to hear.
So you recently retired, right, Willy?
Yep.
Was COVID a big factor in your decision to retire from nursing?
It was the COVID-19 pandemic because, you have to enjoy your work. I mean, work is really not work if you're happy doing what you're doing. But because of the uncertainties
Right.
and all these variants, the threat, the danger is always there. So that's why when the ICU emptied of all the COVID patients, I made a firm decision that it was time to go.
I see. So I know it must be so, as you are telling us the story about taking care of patients using iPad to be an alternate way of doing the emotional piece. That must be tough, was emotional for you to witness, because that's not how ICU nurses deal with emotional aspect of care, right? I totally understand. So now you retired. How do you feel about your decision?
A part of me wants to go back, especially when I receive a lot of emails, we need somebody like this, somebody like that. And then when I go to Christmas parties and other retirement parties, they still ask me to come back because this position got vacated. We need an educational instructor, or we need a manager. But truly, I'm not a managerial person. I don't have the heart to, direct people, what I mean.
Right.
I see.
So, but on the other hand, I'm happy I retired because then I can devote a lot of time. I can focus on my other activities like the upnay.
Right.
And maybe someday the PNAA.
Right.
I think they're running after me now.
Yeah. Do you know of other nurses who made the same decision to retire? Were there a lot of other nurses?
I have at least 2 co-workers who retired prematurely because of COVID-19.
Yeah.
And I have 2 other classmates, 2 or 3, who recently retired because, you get burned out. Not only emotionally, but to me, it's more of a physical burnout because I feel that because I can do a lot of work, I'm the one who's always okay. I start the day as the charge. And then after getting a report for 30 patients, the manager comes to me and tells me we need bed 14 to be on CRRT. So what am I going to do? I mean, I cannot refuse because I know I have the skills, the expertise. So I cannot say, although sometimes I say I already took report but then of course, I mean, yeah, I mean, I just had to get that out of me that, I took report for 30 patients. And then, so what's going to happen now? I'm going to give the same report to another person, the same 30 patients.
Wow.
So what happens in the real world? While I'm assisting the doctor who's putting the permacath, I'm giving report on the side,
Wow.
And then while I'm waiting for X-ray, if it's a jugular placement, I'm giving report. And then, of course, this one, the charge nurse now will keep coming to me throughout the day to ask me, to consult me. So it's kind of like, exhausting already. Like, I mean, I'm doing this one-to-one patient care. I'm still taking care of this charge nurse. And then sometimes I'll be asked to go to the floor to insert an IV. Come on, I can't leave the CRRT patient. That's why it's a one-to-one nursing assignment.
Right.
So, I mean, you can only take so much. So, that was it for me.
So how are you now? How are you?
I'm happy.
Oh, it's nice to. That's good.
I mean, I'm happy. I'm off on all holidays. I'm off on all weekends. I don't have to wake up early.
That's true. That's true.
And even if it's COVID-19 pandemic,
Yeah.
still I have an active social life. So
Oh, good. That's good for you. It's nice to see that you're happy despite all those experiences you had during this pandemic. And I can hopefully what had happened during the early part of this not going to happen anymore. So anyway,
Yeah.
that's all that I have right now.
Right. And that is all that we have for this episode. I want to thank our guests, Willy Ungco, my co-host, Mindy Ofiana, our director and producer, Rodney Cahudo, Carol Robles, the PNAA Chair for Communications and Marketing, our advisor, PNAA Foundation President, Nancy Hoff, our executive producers, PNAA President, Dr. Mary Joy Garcia Dia, and PNAA Executive Director, Carmina Bautista. Join us every Wednesday here on Rise Up. Until then, keep on rising and see you next week. This publication was made possible by Cooperative Agreement CDC RFA IP 21-2106 from the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of CDC HHS.